I won't eat it. Oh, I'll give it rubbish. Chocolate in your mouth.
Yeah. All right. Oh, perfect. Thank you very much. Have a nice afternoon. Thank you. Bye.
And we've got a very full program, and it's gone 12 o'clock, so we'll make a start. If you're working in the hospital or likely to move in and out during the event, we just ask if you can to use the rear door up the stairs there. My name is Steph Coates, and together with my colleague Joss Franciscus, we co-lead the Disability Health Network. We will be your MCs for today's International Day of People with Disability event. Before we begin, some brief housekeeping, if I may. The toilets are located outside in the foyer to the left, down the corridor. And please switch your mobiles to silent, and in the unlikely case of an emergency, just follow the directions of the staff. Can all attendees that are joining us online, and I do believe we've got over 100 that have joined today's session, make sure that your microphones are on mute. And if you have any issues, please use the chat function. Thank you to everyone who submitted questions when you did the Eventbrite registration. We did get a lot of questions submitted. And due to time limitations and for equality during this hybrid event, we won't be taking questions from the floor today. However, the Disability Health Network and the North Metropolitan Health Service team are happy to connect after the event, and our contact details will be shared. This event today is being recorded. You'll notice our Auslan interpreters, Donna Euphemy and Alana Weikart, are with us this morning. Thank you for being here with us. I'll ask everyone to give them a clap in Auslan for them, please.
Welcome everyone to the 2022 International Day of People with Disability event, which is co-hosted by the Disability Health Network and the North Metro Health Service. A big hello to the attendees joining us online today and also in person here at the Harry Perkins Institute of Medical Research. We also acknowledge the many new faces in the crowd who are attending for the first time. This year is the first year that the Disability Health Network has collaborated with North Metro Health Service to co-host this event. We sincerely thank their team for going above and beyond with making today a success, particularly to Lenny Hoskin, Peter Jurgen and Liz Leahy from North Metro, who have done a tremendous amount of work behind the scenes. So thank you so much. And a notable mention to Marlene Parry and Melissa Evans, who have also undertaken a huge amount of work on behalf of the Disability Health Network. I would now like to invite Dr. Shirley Bowen, Chief Executive of North Metropolitan Health Service, to welcome everyone today and provide an acknowledgement of country. We would like to thank Shirley for her support of this event and presence here today. Welcome, Shirley.
Good morning, good afternoon. Welcome everyone. Lovely to see you all here. It's my great pleasure to welcome each of you to this very special event with the Disability Health Network. Before I begin, I will of course acknowledge the past and present traditional owners of the land on which we're meeting today, the Whadjuk people of the Noongar Nation, and also say it is privileged to meet on their land. I acknowledge the contributions of Aboriginal Australians to the health and well-being of all people in this country that we live and we share together, and acknowledge elders past, present and emerging. I'd now like to acknowledge some of our special guests. We're very thrilled to have here Mike Rowe, Director General, Department of Communities, Jenny Campbell, Executive Director, Clinical Leadership and Reform from the Department of Health. We also have Dr Piers Gooding, Senior Research Fellow from Melbourne Law School, who will be joining us today via teleconference from Melbourne and delivering a keynote address. I'd also like to thank our panel members, which I'm sure you'll enjoy the discussion with. International Day of People with Disability is an important day for us, and I'm pleased to see that so many people are here and also attending online. Today's event is an opportunity to celebrate the many contributions that people with disability make to Western Australia and to our community, and to learn more about improving the accessibility and inclusiveness of health services for people with disability. The theme for today's event is supported decision-making in health, which involves supporting someone to make decisions about their health and future healthcare. A really, really important topic. To explore this theme, the event will have keynote speaker Dr Piers Gooding and a panel discussion. Also today, I'm very pleased you'll find in your packs the newly revised hospital stay guidelines for the North Metropolitan service, and also our disability service, our health service disability access and inclusion plan 2022 to 2027. So they're there for you to read, and there will be more discussion of those later. Both of these are valuable resources which hopefully will make our health service more accessible and more inclusive for people living with a disability. Our diversity and inclusion strategy also guides us in fulfilling the North Metro vision for an equitable, accessible, culturally safe and inclusive health system and service. I'm delighted that we're able to join today with the Disability Health Network to launch and host this event. I sincerely hope that you find it valuable, interesting, and walk away today with new thoughts, meaning, and real care for how we can make our service more inclusive for people living with a disability. Thank you.
Thank you, Shirley, for the welcome and the acknowledgement to country. I would now like to introduce Megan Burley, Director for Health Networks at the WA Department of Health. Welcome, Megan.
Thanks very much, Steph, and thank you, Joss, as leads of the Health Network. And thank you very much, Dr. Shirley Bowen, for your speech, and also acknowledging North Metropolitan Health Services to host this event today in partnership with the Disability Health Network. My name's Megan Burley, and I'm the Director of the Health Networks. And this event has a real soft spot in my heart because I was one of the instrumental senior development officers who established the Disability Health Network and ran their first event celebrating International Day of People with Disability back in 2013. So it's just fantastic to come here today and acknowledge and recognise this day, the International Day of People with Disability, with you all. For those of you who aren't aware, International Day of People with Disability was first proclaimed by the United Nations back in 1992. So this is almost a 30-year celebration. It's a United Nations sanctioned day that's celebrated usually on the 3rd of December, but given that that's a Saturday this year, we thought it's probably better to hold it on a day during the week. It aims to increase public awareness, understanding and acceptance of people with disability and celebrate their achievements and contributions. The day also aims to promote an understanding of disability issues and mobilise the support for the dignity, rights and well-being of people with disability. And I recognise this as a very important day because not only did I work with a number of people, quite a large caseload of people with disability in my days as a clinician, but I have the pleasure of having a beautiful niece who also has a disability. As I mentioned, the Disability Health Network was first started in 2012, and this event, its first event 9 years ago was in 2013. And in the past few years, it continues to grow in strength and in interest, and we've had hundreds of people attend this event, both in person and online. Each year, there is an international theme and a state theme for International Day of People with Disability. This year's state theme is Leading the Change, and it encourages everyone to commit to making sure opportunity, inclusion and access is available to everyone. This is relevant to the theme of today's event, which Dr. Shirley Bowen mentioned, which is supported decision-making in health. And supported decision-making involves helping someone make an informed decision about their life. And by supporting people with disability to make informed decisions about their health, we can lead the change in improving the accessibility and inclusivity of health services for people with disability. And it's fantastic that today you're also seeing the revised version of North Metro Health Services Disability Access and Inclusion Plan, which will put this health service in good place to be supporting people with disability in supported decision making. The other important thing that's been going to be launched today is the revised disability hospital stay guidelines. So they're going to be launched today, and many of you have a copy of them which are hot off the press, and I can tell you they are hot off the press. The guidelines were first published back in 2016, and which outlined a best practice mainly to be supporting disability service organisations when better managing and preparing their residents in having a hospital experience. But a lot of things have changed since 2016. Some of you might have heard of the National Disability Insurance Scheme, and that was a significant change to the landscape for people with disability in Western Australia. And it was really vital, the Disability Health Network identified that it was vital that the guidelines were updated and made current to acknowledge and incorporate that shift to the system, which really is a scheme that is focused on supporting the decision making of the person with the disability for what they need to live a full life. So rigorous consultation was undertaken with a variety of stakeholders, and it was created into 3 separate parts. So that consultation was with people with disability, their families, friends and carers. It was with disability service providers, peak disability bodies and hospital staff. So I'm really confident that these new resources tailored to the specific groups of people that work and support people with disability and those with disability themselves will help guide and inform to improve the hospital experience for people with disability. I'd really like to congratulate the Disability Health Network for their hard work and all of their efforts in hearing those stakeholders during those consultations and finding ways to incorporate what they were hearing into these documents to make them the most useful and accessible documents to help with the shared decision making. I hope that everyone enjoys the event, and like myself, I'm looking forward to learning more things about supported decision making and hearing about a few of the other things that are being launched. And please do join us afterwards for some light refreshments and networking. Thank you.
Thank you, Megan, for your words. The Disability Health Network aims to improve the health outcomes for people with disability across the health interface. In 2022, the Australian Institute of Health and Welfare reported that, in general, people with disability experience poorer general health and higher levels of psychological distress than people without disability. Adults with and what is often referred to as profound or severe disability are 12 times more likely to experience a very high level of psychological distress. Many people living with disability report difficulty accessing services. Clinical care is only a part of what influences a person's health. Other factors, such as a person's environment, access to healthy food and support with exercise and mobility, is also crucial. Be it in hospital, with a GP or in a person's home, we all have a responsibility to work with the person and their supporters for better health outcomes. Today, we hope that all of you will be champions in leading that change.
This slide that you have before you highlights some of the work we've done this year on revising the hospital stay guidelines, developing the disability health profile form, and arranging some key presentations on a range of topics. We also held a forum for people with disability in February this year in regards to COVID. In your packs, or for those here today, you will have picked up a DHN highlights sheet, which looks like this. Our key focus for 2023 will be implementing the hospital stay guidelines, which we are here to launch today. The hospital stay guidelines, as Megan mentioned, were first launched in 2016, and the landscape has changed a lot since then. The revised hospital stay guidelines aim to inform every one of the key stakeholders of their respective roles and responsibilities throughout a person's hospital stay, with the goal of improving the hospital experience and empowering people to have more say in their healthcare. We know that one of the key enablers to people with disability leaving hospital when medically ready is early communication and collaboration to ensure effective discharge planning. These guidelines provide strategies and to improve communication across the health and disability interface. The guidelines, as Megan mentioned, are now in 3 parts, and they're designed to complement each other. The first is a guide for people with disability, their families, friends, and carers. The next is a guide for disability service providers and support workers. And the final one is a guide for hospital staff. All of the guides are rich with images of local people with a diverse range of disability and also with photographs of their supports, as well as clinicians from our hospitals. We acknowledge those for their contribution, some of whom are with us here today.
Thanks, Steph. We will now briefly touch on the 3 guides within the hospital stay guidelines. So firstly, a guide for people with disability and their family, friends and carers is aimed at empowering people with disability and their supporters to be more involved in a hospital stay and communicate their needs and preferences while providing practical advice on how to navigate a journey into and out of hospital. It is written in plain English to connect people with relevant supports throughout a hospital stay as well as in the community. Provide practical tips and tools on how to share information for improved healthcare outcomes. Some of these examples would be health passports, social stories, online tools, and other helpful documents. And lastly, to provide clear pathways for people with disability to escalate their concerns and to have more say in their healthcare. Both hospital stay guidelines, a guide for people with disability and their family, friends and carers, as well as a guide for disability service providers, all have 4 sections. Firstly, being prepared for hospital, then going to hospital, at the hospital, and finally preparing to go home. Our hope is that this resource will be used as a practical point of reference for people with disability. We encourage people to connect with the resource online through the QR code featured on the screen or through an alternative format if requested. We aim to launch the easy read version of the guide for people with disability and their family, friends and carers early next year. We'd like to acknowledge Ari Wilkins from the Department of Health Communications team for driving this work. I would now like to introduce Danielle Loizu-Lake, who is one of the authors of the guidelines to discuss the guide for disability service providers. Danielle is a health professional consulting in the social services sector. As an advocate for women and people with disability, she's an active member on a range of community services boards and committees, including the Ministerial Advisory Council on Disability. She's also the founder of Paper Planes Support Coordination. Welcome, Danielle.
Thanks, Joss.
Thank you.
I'd like to acknowledge all of the disability service providers that have joined us here today and for your commitment to supporting people with disability in their health decisions. Organisations, support workers, support coordinators, communication partners and community therapists all have an important role to play in supporting a person with their hospital experience and communicating their health choices. The hospital stay guidelines, the guide for disability service providers, establishes a framework on how this can be done. And that is so a person's health choices and preferences are known. People involved in that person's care have a better understanding of what health support they may need and therefore what their role is in supporting that and what their role is not in that. What the person they're supporting may want when they're in hospital, These could be things like aids or equipment, and have they had the discussion on how those aids or equipment are going to get to the hospital? Who is the best person to support that person in hospital? Is it a paid person or is it an unpaid supporter? Have we prepared ways to communicate information and preferences with hospital staff, GPs and support people? The disability health profile form, that one-page form that you'll see when you come in, which is part of the hospital stay guidelines, is a way that this can be done. A health passport and an advanced health directive is also another way. We all need time to think about our health choices and preferences. All of us do that. That's part of our regular life. So if you're supporting a person with disability who wants to think about and plan for their health decisions, you can use the guidelines. The more that we are empowered and we're managing our own health care, the better we are to make these health choices. And of course, the better our health outcomes. So being across this information as a disability service provider is not a nice to have, it's actually crucial in supporting a person. Particularly if you're supporting a person with NDIS, because you need to be across what their disability-related health supports may be. And you may need to be able to comment on those things when needed. There's a QR code up there. So we encourage you, if you're a disability service provider, to download a copy of the Hospital Stay Guidelines for Disability Service Providers. And yeah, I think that's pretty much it, Steph. Over to you.
Thanks, Danny. Now, firstly, a shout out to all the hospital staff in the room. I do recognise a couple of you. So thanks for being here, and also to all of those that are online. And a very, very special shout out to Megan White, who is joining us online. I'm not sure, Megan, if you can, I was probably not going to be able to be seen on the big screen here. I was going to see if you could give us a wave. Megan wrote the guide for hospital staff when she was in the role of team leader in the Fiona Stanley Fremantle Hospital Group NDIS linkage team. The guide for hospital staff has been written by hospital staff for hospital staff, with input from relevant agencies and disability organisations. It contains a raft of resources and person-centred practice stories, so if you are a hospital staff member, do take the time to check out the document in full and have a look at the appendices. The Guide for Hospital Staff outlines what is the hospital's responsibility and what is the NDIS's responsibility, particularly in relation to setting expectations and collaborative discharge planning. If you have a person in your care with complex communication needs or challenging behaviour related to their disability, and you are struggling to provide safe and equal care, consider what you would do if you were caring for someone with the same ailment without the disability. Ask yourself, can I do the same assessments, tests and interventions? If the answer is no, you must seek to have a support person who knows them well, to be a communication partner or to assist with managing behavioural support needs so you can provide the necessary healthcare. This is one of the many points made in the guide, and so I implore hospital staff to read and use this best practice guideline. We all want people to have equally good health outcomes, so please access the guide for hospital staff via the QR code on the screen. I'd now like to draw your attention to one of the resources that's been mentioned a few times. It's the Disability Health Profile Form, which is designed to be a medical record form. Over to you, Joss.
When revising the original guideline, it became clear that a concise one-page form needed to be created to convey key disability-related information for hospital staff on admission, much like a one-page health passport that can be entered into medical records. The new Disability Health Profile form captures information about a person's disability that is useful and quick reference for hospital staff. It seeks to improve the transfer of information between hospital staff and the person's family or support staff. We encourage people with disability to present a completed disability health profile on admission to hospital. Disability service providers to have an up-to-date version of the form completed and ready for a person's admission. And hospital staff to use the form and try to get it accepted as a clinical form at your hospital so that it can be stored in medical records. We are aiming to make this an interactive form on our website for people to access in the future.
So now just briefly, we'd like to share our focus for 2023, which is the implementation of the hospital stay guidelines. So if you could please pull out your phones and help us by completing one of the surveys on the screen that's relevant to you. Even if you just open the survey now and complete it after the event, we'd really appreciate it. We'll also share the links after the event, and for those online, hopefully you can see that on the screen. We don't want these guidelines to just sit on the shelf. The network is committed to working with stakeholders to identify how to encourage uptake of the guidelines. Therefore, we want people to know they exist and to use them, and we're seeking your input in how to best do this. We're running a series of engagement opportunities with people with disability and their supports, disability organisations and hospital staff to identify the main priorities for taking the guidelines and putting them into practice. We would greatly appreciate your time and thoughts to help support the uptake of the guidelines as much as possible. And now it's time, I'm sure you're all ready for this, to move on to our speakers. And it's my great pleasure to introduce our keynote speaker, Dr Piers Gooding. Dr Gooding is a Senior Research Fellow at the Melbourne Law School at the University of Melbourne. He is a socio-legal researcher who examines disability and mental health law and policy. Dr Gooding has acted as a board member and advisor in a range of local, national and international bodies working on the rights of people with disability, and has advised policymakers at national and international levels. It gives us great pleasure to welcome Dr Gooding here today. He's joining us from Melbourne as an expert in the field to discuss supported decision-making in a healthcare setting from a human rights and legal perspective. Welcome, Dr Gooding.
Hi. Thank you. Hi, everyone. I'm just going to assume that you can hear me, and if not, please just wave your hands around wildly. Thank you so much to the organisers, and I want to first congratulate the authors of the resources. I'm really pleased to take part in this. And I'm coming to you from the land of the Wurundjeri people of the Kulin Nation. So in addition to the Whadjuk people of the Noongar Nation, I'd like to pay my respects to their leadership. I'd also like to acknowledge people with disabilities, who today is all about, and acknowledge their long-standing leadership and contribution in Western Australia and internationally, including in the health workforce on all of the things that we're discussing today. So I'm here to talk about supported decision-making, which is a concept that has become prominent in various areas of health and social service provision, and which is strongly based in international human rights law. But I really want to bring it down from the lofty heights of international human rights law in Canberra or Geneva to the real lives of people who it's meant to benefit. So I want to tell you about a real person, Chris. And Chris is a 40-year-old Melbourne man. He's a committed sportsman. He's played in local basketball, cricket and footy leagues. He's a keen swimmer, and he's worked in lots of jobs, including gardening, food preparation and factory work. Now, he's got really strong relationships, and he often plans birthday cards and presents many months in advance of various people's birthdays. He also has an intellectual disability, and Chris has accessed some form of support service or another since he was a teenager. Now, I asked Chris before coming to this event today if I can share some aspects of his life from my view, and he said yes, but he wanted me to share this photo of one of his proudest achievements as a basketball player. And I want to tie Chris's experience of health services over his life to broader societal developments, I suppose, that have occurred in laws and policies and practices here and overseas. So supported decision-making is really exactly what's written on the tin, being supported to make decisions. And this concept gained prominence with the UN Convention of the Rights of Persons with Disabilities, or the Convention, which came into effect in 2008, as has been discussed. Now, the committee that oversees the convention describes supported decision-making this way. Those assisting a person may communicate the individual's intentions to others or help him, her, understand the choices at hand. They may help others to realise that a person is someone with a history, interests and aims in life, and is capable of exercising legal capacity. The individual is the decision maker. The support persons explain the issues when necessary and interpret the signs and preferences of the individual. Now, the committee points to several articles in the convention to which governments like Australia must adhere. And important here is Article 12, and it requires governments to recognise that persons with disabilities enjoy legal capacity on an equal basis with others in all aspects of life. And legal capacity essentially just means that a person is legally recognised as a person who can make decisions. And Section 3 requires governments to take appropriate measures to provide access to the support they may require in exercising their legal capacity. Access to the support they may require in exercising their legal capacity. So what kind of support might that be? I'll go through that shortly, but for now, just to say that this way of expressing it drew from the leading work of people with disabilities, their families and others in places like Canada and Scandinavia. And this is an image of members of the Canadian Association of Community Living. And this alliance was really prominent in challenging the idea that people with intellectual disability were unable to make decisions for themselves. And they pointed out that it wasn't generally the person who was incapable of making decisions, it was society that was unable to provide the right decision-making support. And this idea has been advanced by advocates with intellectual disabilities in particular, all over Australia. And here's the reinforced self-advocates from Melbourne in a classic laneway, and they've been very vocal on this front. But let me put it another way. There are people in this image who use wheelchairs. Now, if a person who uses a wheelchair can't get into a bank or a hospital without ramps, we don't say that she or he is incompetent at financial management or personal health care. What we say is that people using wheelchairs need ramps to enter the bank or the hospital. They might need accessible bathrooms, regulation door widths, ATMs and door buttons that are placed at the right level, and a range of accessibility requirements. Well, effectively, it's the same with decision making. Now, some people need more decision-making ramps than others, and they may need help understanding, communicating and putting their decision into effect, but the right support can ensure that they are able to direct their own lives. And I think this analogy is also helpful because accessibility measures improve access for everyone. So just as ramps benefit people with a range of needs, physical impairments, temporary injury, people pushing prams and so on, so it is that when decision-making supports become the default, there are going to be flow-on effects for others. And this could include access for people with low literacy, trauma survivors for whom encounters with healthcare providers can be really hard, and people whose first language isn't English, just to name a few. But despite these benefits, there is something, I think, about intellectual, cognitive and mental health related disabilities in particular that make it far more likely that those individuals will be judged or written off as incompetent. And sometimes this is explicit, so in law where someone is deemed to lack mental capacity, and sometimes it goes unstated. And some disability advocates have argued that many parts of society really grossly undervalue the capabilities of people with disabilities. And that includes in the places that they go to for help. So here you can see in the image former Disability Human Rights Commissioner Graham Innes, who was involved with the drafting of the convention. He calls this the soft bigotry of low expectations. Chris experienced this when at 20 years old, a healthcare worker said he was incompetent. And the professional rarely spoke to Chris directly when he was in the room, often talking about him in the third person to his family. The doctor told Chris's parents that decisions would need to be made in his best interests. And when his sibling raised the concern that Chris could make decisions, the health practitioner said to his family, well, watch this, and asked Chris, you don't need to take these medications, do you? And Chris agreed. Then the professional said, on the other hand, you don't need to take these, you do need to take these medications, do you? Chris responded, no, I don't need to take them, and became quite clearly flummoxed and confused. And the professional seemed really vindicated that Chris was easily misled and tied in knots, and so therefore couldn't make decisions about his healthcare. Now, Chris's family, I'm afraid, accepted this, but later read about research showing that people with intellectual disabilities will often agree when people ask them a question because they might feel embarrassed to explain that they don't understand, or agreeing to things can make it socially a bit smoother. And this really fitted with Chris's responses. And as would become clear later, Chris really had to develop confidence to make decisions because people had really always made them for him or devalued his viewpoint. And this message had really been reinforced by a range of professionals who'd encouraged his parents to be in the driver's seat. However, over time, after Chris and his family learned more, they did realise that he was more open to expressing his views when he knew a person and had a rapport and a sense of trust. And in time, he changed the healthcare practitioners in his life to those who took time to explain things. Now, his current doctor is someone who speaks directly to Chris and only invites family in for specific matters after receiving Chris's agreement. And this approach really fits with major research into supported decision-making. An example is the La Trobe Support for Decision-Making Practice Framework, and it places knowing the person as the first and the very foundation for supporting decision-making. The framework is based on some of the most comprehensive empirical research on this subject in the world, and it's led by Chris Bigby and colleagues. And I'd strongly recommend this resource because it really provides practical material for family and service providers, much like the resources being launched here. And this point about families and informal supporters is really important because for some patients, family members and informal supporters really should be engaged by healthcare practitioners. I don't need to tell anyone there. Because there are really some dreadful stories about people's deadly symptoms being wrongly dismissed as part of their disability. And that includes in situations where a family member is making very clear that what is happening is out of the ordinary and a sign of very serious distress and pain. Now, another key article in the convention is Article 19. It's not as directly relevant here, but it's important because it establishes the equal right of all persons with disabilities to live in the community with choices equal to others. And it requires that governments take steps to ensure their full inclusion and participation in the community. It's hard to think of healthcare as being, anywhere more important than healthcare. And you'll see a man named Robert Martin in this photo, who is New Zealand's current representative on the committee overseeing the convention. And he's the first person with an intellectual disability to sit on a UN Human Rights Treaty committee. And incidentally, he spent the first decades of his life institutionalised. So most of the safeguards we enjoy in life arise from our families and social networks, and hopefully we're surrounded by natural safeguards. So someone embedded in a community in a meaningful way will have people looking out for them. And research by Chris Bigby and colleagues suggests that a person is more likely to have greater agency when there are a range of people, a diversity of people in the person's life, rather than a high dependence on one or two. So instead of focusing on natural safeguards, often the focus turns to regulation, protection and management. But the risk is, despite being well-intentioned, they can easily turn into a euphemism for intrusion and disempowerment. And it's also important to remember that we all make decisions with support from others. This was pointed out earlier. And it's led to some saying that we should be thinking about autonomy less as a matter of isolated, independent and very rational decision-making, and more as a matter of relational or interdependent autonomy. And another key point here is that people are entitled to make mistakes because it's a big part of how people grow. But it's often a part of life that people with disabilities are denied. And sometimes this is referred to as having the dignity of risk. I should say quickly, this is not to suggest people should suffer from a hands-off kind of approach where risky decisions are treated lightly. It's not about leaving people to suffer in isolation or leave them in situations of avoidable risk, but risk does have to be counterbalanced by access to proper information and support, and by principles of harm minimisation potentially. A key idea here is positive rights, which is another way of saying that resources are needed to help a person be directed by their own will, preference and values. And on this point, I just wanted to briefly acknowledge leading work in WA at the Mental Health Commission, which promoted informal safeguards quite early on to help protect individuals from exploitation and harm, but at the same time enabling the person to make choices, take risks and live a life that reflects their personal preferences. And I referred to that in my book on supported decision making. But returning to the convention, Article 25 is vital here, and it requires that governments recognise the right of persons with disabilities to the enjoyment of the highest attainable standard of health without discrimination on the basis of disability, including on the basis of free and informed consent. So, quickly, what has Australia done to make supported decision-making a reality for people with disabilities and others? Well, first, there's been major law reform activity. Here you can see the inquiry by the Australian Law Reform Commission into disability, equality and legal capacity. And they established back in 2014 these principles for decision-making, and they'll be updated with the findings of the Royal Commission on Disability Services that is underway. And then there's the NDIS, of course, which in the legislation requires that people with disabilities have the same right as other members of Australian society to be able to determine their own best interest, including the right to exercise choice and control, and so on. And in the health context, there is now bipartisan support at the federal level for a national policy plan on improving the health of people with intellectual disability. And one of the first aims is to ensure people receive reasonable adjustments and supported decision-making. And this aim has echoes in broader movements towards promoting the autonomy of patients. I heard before about shared decision-making, and this action you can see on the screen comes from the National Safety and Quality Health Service Standards Guide for Hospitals and requires clinicians use shared decision-making to improve person-centred healthcare. I'd say shared decision-making is slightly different from supported decision-making, which I won't go into here, but there is lots of overlap, and that's the most important thing. There's also a slew of resources available from advocacy organisations, services for people with intellectual disabilities, in aged care, in mental health care, and I'll share these slides with organisers afterwards for anyone who's interested. There are also new mechanisms in law at state and territory levels. In Victoria here, in Chris's jurisdiction, there's a Powers of Attorney Act which changed to allow for a new type of power, the supportive attorney, and that allows someone to be appointed to assist a person by gathering information, communicating with relevant parties and helping the person to communicate that decision, but they can't go over the person's decision making. And this can be quite helpful for families and supporters who might be dealing with third parties like banks and real estate agents, because it gives those third parties confidence that this person who's supporting has a formal role and they're not just someone who might be exploiting a person. Now, Chris has actually got 2 family members who are listed as supportive attorneys, but actually they don't often need to use them because together with a small dedicated group of support workers, Chris has really achieved lots of goals in life, including living independently near public transport so he can easily travel to football games and other big sporting events. And even supportive workers in the past had really doubted Chris's wish to live in this way. And his family and he were repeatedly pressured to accept the narrow choice of a group home, which was presented as a logical and inevitable housing arrangement. But instead, with a new range of laws, policies, service models, Chris was really offered support to build up to big decisions and a range of good options with which to, from which to choose. Now, he's been successfully living independently with support for almost 5 years. He's known in his community, has good relationships with his neighbours, and he has, most importantly of all, I think, a sense of belonging. Now, you've probably guessed it, but Chris is someone quite close to me. He's my brother. And let me tell you that this is just a tiny glimpse into the journey that he's been on to get to this point. Now, some of you will probably think, well, that's all well and good, but Chris seems like he has skills that allow for independent living and he's got supportive family. But what about people without that or with more profound disabilities? Well, I'd ask you to suspend disbelief and I'd direct you to the tremendous work of Professor Jo Watson from Deakin University, and she's been doing some world-leading research on communicating with people who have profound cognitive disabilities, and that includes people who don't use spoken language. And she's pursued world-leading work on how support people can better interpret the wishes and preferences of a person with profound cognitive and communication disabilities. And if you think, well, Chris had support from a young age, well, what about those who are in aged care and don't have these opportunities? I'd direct you to a person named June Arthey, whose story is captured on a website I helped created, and it demonstrates that living independently and being included and contributing to community can happen late in life. June lived in an institution for 40 years and then became lost in the abusive private hostel system. And she was looking to be locked away forever, but a committed advocate supported her wish and vision. And a committed group helped June set up her own home, and doing so required a lot of work to give her the confidence to make decisions, first about small things and then bigger things like what kind of home she wanted. And that website I mentioned is called 19 Stories, and it includes some great stories of independent living. And a quick shout out to one of the WA organisations involved, Valued Lives, a peer community organisation. And another shout out to the WA Individualised Services, who I understand will be chairing a national community of practice on supported decision making in 2023. So there's lots of momentum, and it's not, I hope, just another fad. And you might be thinking, well, that's all good, but what about in hospital and other healthcare settings where staff are under-resourced and overworked, where difficult decisions have to be made under great pressure? Well, I liked this cartoon and thought that you could change it so the two figures were very weary healthcare workers who were bruised and exhausted, and looking sceptically at people saying there's a paradigm shift on the way. Now, I'm not going to pretend that I have answers for that, sitting here in a law school about how to apply things in the healthcare system. But the truth is you'll all be better positioned to reflect on what that might mean. And that's exactly how it should be, I think, with any law or policy reform. Really, on their own, changes to legislation or human rights law can't do much. But when they do have big impact is when a whole range of people are given tools and ideas to do what's needed in a range of environments, from a GP's office, a specialist cancer ward, emergency departments, psych wards, dental clinics, and so on. And when you think about what all the small groups of people have achieved, who I've spoken about in spreading these ideas around the world, including people there I know in that auditorium, and what that has meant on an individual and community level and internationally, well, it really does go to show what kind of transformation is possible. And I think I'll leave it at that. So thank you very much.
Thank you, Dr. Gooding, for your valuable insights on supported decision-making, autonomy and dignity of risk. Now it is time for our panel discussion. I'd like to invite our panel members to the front of the room. We'd like to reintroduce Danielle Loiseau-Lake, who will be facilitating the panel. Over to you, Danielle.
Thanks, Jocelyn. Could we have our panel members make their way down? Just give everyone a little bit of time while I recap on some of those important things that Piers spoke about. So thanks, Piers. That was a lot of information, very insightful, but hopefully thought-provoking for the people here in the room, because we are all those different groups of people. There are health staff here, there are people from community services, and there are people with lived experience in this room and online. So, okay, great, we're all here together. So we all do have a responsibility to figure out what this may look like for us in our lives and practice into the future. We heard Piers say that supported decision-making is a fundamental right for people with disability. I'd like to highlight that that also includes for people with mental illness. We had a lot of questions when everybody registered. There was a lot of energy around this conversation, and I thank you all for your questions. We will endeavour to discuss those on the panel now, today. And if you do want follow-up, you can also ask for it through the survey, through the QR codes, for us to get back in contact with you. So what does supported decision-making look like? I'd like to introduce our panel members to help us nut that out a little bit more. We've got Susan Stanford here with us. For the past 25 years in government and community benefit organisations, Susan's work has focused on building individualised supports around people with disability, which facilitates them leading their lives. Most recently, she's coordinated a national project to build decision-making capacity, build decision-making capability, rather, around decision makers with complex communication access needs. managed by WASTE, WA Individualised Services. That was the photo we saw earlier. Susan, you're committed to building a more kind, equitable and just Australia for all people who live here. So if we can welcome Susan, thank you. Hello down there. We've got Sam and Alex. A lovely photo of these two up here behind me, which I think reflects their relationship well. Sam and Alex have been friends since they met at an Aboriginal Advocacy Network meeting by the First Peoples Disability Network in 2013. Geez, that's nearly a decade, you guys. Have you got plans to celebrate 10 years of hanging out together?
No, we did that on Sunday.
Oh, good. Now, in her early 40s, Sam, you maintain your love for the West Coast Eagles, your cat Mallow, and living life in your unit your way. You were born with cerebral palsy and you moved into supported accommodation after your mother passed away when you were 18 years old. People who often don't know you find it sometimes difficult to understand what you're saying, and sometimes they assume that you can't make decisions. Despite having to battle your entire life to be heard and understood, you've persisted. Your determination to live your life your way is aided by your cheeky sense of humour and your infectious smile. So thank you, Sam. You can welcome Sam here today. Alex. Alex is Sam's supporter, and Alex, you're a dedicated grandfather, father and husband who believes in social justice and universal kindness. Both Sam and Alex share a love for AFL with a healthy rivalry supporting opposing teams. Together they've navigated Sam's health challenges, working hard with many hospitals, GPs, community nursing and disability support staff to ensure Sam's health needs are met. They are a formidable pair and a great example of how we can provide support to ensure a person with disability can live with dignity, be active in developing their health literacy and make informed choices. So if you can welcome Alex to the panel. Okay, we've got, paper. Rachel next to me. Thank you for joining us, Rachel. Rachel Zomba is an experienced clinical neuropsychologist who's worked across the mental health, general health and disability sectors. Your area of clinical expertise is in capacity, and you have a general interest in empowering people with cognitive compromise to be as autonomous as possible in decision making. Rachel is currently the operational co-director for the specialty mental health services within the North Metropolitan Health Service, including older adult, youth forensic, eating disorders, neuroscience, and the Centre for Clinical Interventions Mental Health Services. And you're appointed to the Psychology Board of Australia in 2002. Welcome, Rachel, please. And our last panellist, Dr Sukley, thank you for joining us today. You are a geriatrician working at Sir Charles Gairdner Hospital and Osborne Park Hospital, and you look after older people across a variety of settings, including emergency, inpatient wards and outpatient clinics, and you have a particular interest in looking after people with dementia and supporting them and their families in care. If you can welcome Dr Sukley. Okay, straight into the questions. So Susan, I'm going to have you up first. So a little heads up to be ready. I think one of the first questions that a lot of people ask when we talk about supported decision making is, well, what is the role of the supporter? And in this context, what is the role of the supporter in supporting a person's health decisions?
Just before I do, I just wanted to show you a beautiful piece of artwork. Sorry, this was unscripted. This is by a local Batamaya Yamaji Nyunga woman, Gertrude Hayden, who we asked at WASTE to represent for us her understanding of supported decision making. She's given us a really rich description of it, and I just imagining that in this room there are probably some people who would find it easy to engage with a beautiful piece of art in terms of building their understanding of what we're talking about. So what was the question again?
It's a big one. What is the role of a decision supporter. So in this case, Alex would be Sam's decision supporter. So what is the role of a decision supporter in supporting a person's health decisions?
Okay, so I'm going to expand my thinking around what a decision supporter is, and it's not just one person. Okay, so health professionals in this kind of context bring the great value of knowing what the decision is to be made and the information about that, the whole context for the decision. And what Alex would bring is a deep knowledge of the person he's supporting, of Sam. So together, the concept of supported decision-making distributes decision-making capability across the decision-maker and their supporters.
Across the decision maker and their supporters. So what does, who does that, and I know that another one of Sam's decision supporters is in the room, and that's from Sam's disability service provider. So it's all very formal language, isn't it? But it doesn't feel like it when it's happening in real life, does it? Those people, they know that person, it's relational, and because of that historical relationship, they may know from the look of an eye or you know, that person's not into something.
Yeah, so we all know that words are really kind of overrated a lot of the time, that we're actually communicating in so many other ways than just words. And that's the value of long-held relationships. We know that so well about ourselves, and our partners know that about us really well as well. So there's a whole lot of other ways that people are communicating their will and their preferences in relation to a particular decision. And I would imagine as health professionals, if you're talking through a decision-making opportunity, you could be noticing and checking in with the supporter and interpreting back to the decision maker what you are noticing and their indications of preference about what you are saying. For example, if you were using some visual supports to actually show someone this is an MRI machine, you're going to have an MRI, that's the decision to be made, and the person is looking intently at the image, you may interpret that and reflect back to the person, I notice you're looking closely at that. I wonder if that means you would like to go and look at that machine. Perhaps we could go and check it out and you can get some more information about what's ahead of you. Alternatively, the person may be looking out the window, you might interpret that as maybe you're not interested, maybe you're feeling some anxiety about that, and then that would be a key opportunity to reflecting with a decision supporter who's known them a lot longer and who is in a better position to interpret all those expressions of communication.
Yeah, thanks, Susan. Rachel, when we had a chat before today, you mentioned that the current legislative, that's some wind out there, the current legislative framework allows for a substitute decision maker rather than supporting an individual to make decisions. I just want to preface the question I'm going to ask you. For those of you that are online or in the room, some of you will know what Rachel's job is in the health system when I say a clinical neuropsychologist, but some of you may not know what that is. Can you very briefly explain what you do when someone, you know, has to make a decision in the hospital? What your role is?
Sure. So usually people who are referred to neuropsychologists have some form of brain injury or brain impairment, something that affects their central nervous system or some aspect of their thinking. It might be a head injury, dementia, it might be a chronic mental health condition. It might also be other kinds of conditions like chronic substance use or alcohol disorder. So usually I'm referred people who we have a question about whether or not they can make a decision, whether they have the capacity to do that. So they're the kinds of people that get referred to a neuropsychologist. Usually we see the more complex cases, so they're not usually very straightforward. So usually we wouldn't see me unless there's it's really unclear to the team or to other people. Part of our role is assessing whether or not someone can make a decision, but that should be a small part of our role. It should also be about understanding how someone processes information, what they understand, and finding ways to present information to them, informing them as best as we can so that they can have everything available to them to make decisions that they're able to. And often people make a judgment fairly quickly that they can't make a decision about something, but it may be because they haven't been given all the information that they need, or in a way that they require it, or they haven't been given the supports to actually respond to that information.
Yeah. Thank you, Rachel. I am going to come back to your question, but I feel like what you just said is a really good segue to ask Sam a question. So Sam and Alex, Sam, when you've been to hospital before, and some of those times that you've been to hospital, you haven't been supported or you haven't been able to communicate what you want to the staff at the hospital, be it the medical doctor or the social worker. What's happened to you in the past when you weren't able to tell them what you wanted to tell them about what you were feeling? Can you say that again, Sam?
When they ignore her.
When they ignore you? Yeah. And when someone has ignored what you're trying to tell them, what has happened because of that? Can you think of any situations, and we're not trying to, because you've had some not so good, but also some very good health experiences in hospital, but those times when it wasn't so good and you couldn't tell them what you wanted and they were ignoring what you were saying, what happened? What were some of the issues that happened because you couldn't tell them?
Pain wasn't managed properly.
So Sam, when we met about this and you were telling me about the tablets, do you remember when you were trying to get ready to leave hospital? Tell us about what happened with the problem with the tablets that you were trying to tell them.
Can't take them, she can't swallow tablets very easily. She needs oral medications.
Yeah. So you were given some tablets that were really big and you were trying to tell them that you can't take them. And I think you were quite worried because you knew you needed to take the medication so you could be well and not come back, but you couldn't physically take it. So what did you do? Can't remember. I think you might have, I think you and Alex jumped to action. And Alex, do you remember what happened with those?
So I do. They may have ended up in the rubbish bin and then we'll have got back to the provider.
Right, yeah. So luckily I took notes when we had our chat. So I think what happened was, you're right, those ones did go in the bin. Alex and Sam, you had a discussion about it and you figured out the problem. And then you went back to the GP at Derbyl Yerrigan and you found out that you could take some that were effervescent, that turned into the water. So Sam, do you still use those ones? Are they good for you?
That's potassium.
Yeah, you take that every morning now. Yeah, great, thank you. Well done. Okay, back to you, Rachel. So when we're thinking about the health system, the Western Australian health system, this is a double-sided question, so hopefully you can provide both sides. What are the opportunities for supported decision-making in health? But perhaps you need to also identify what the limitations are in that context.
I'm going to start with the limitations.
Okay.
So just call that something that actually Dr Piers Gooding said, and that we have resource limitations and system pressures. It takes a really long time to do a really good job and to be comprehensive and to ask everything that we need to ask and to find out what we need to find and to do that in a way that's appropriate for the person in front of us. And we are being asked to operate in a system where we get asked to do more every day with less, and please do it more quickly. So I just want to call that out to begin with, that is a limitation, and we have to find ways to work around that and to work in that system to still deliver the kind of care that we need to. Something that strikes me is, I guess, what I would categorise as the medical system's history and our values. We really operate from a doctrine of do no harm, which means that we are always trying to make the person better. And we also have in our history that the doctor or the health professional knows best. So we are the experts. And I think what happens is that means a number of things. When people do things that we perceive as being against their own best interests, or that they are things that we perceive to be detrimental to themselves, it's really hard for us as health professionals because we want to make people better, and we always try and do things that maximise people's abilities and their lives, and it's hard to watch people who make decisions to do things that make themselves more unhealthy or worse. And it's also something that Dr Gooding touched on in his talk about that dignity of risk. And one thing I find is that the standards for people living in the community can be different than the standards we apply for people in the hospital. We have so many people in our community who make all sorts of decisions, and we don't go around trying to find people who make bad decisions and impose restrictions on them. But when people come into our health system, we do often demand that they make a different kind of decision or expect more from them than we might from the general community. So I think that can be a limitation. However, I think that it is changing. And I'll get onto the opportunities in a minute. One thing you did touch on is our legislation. And the laws in Western Australia around decision-making, around guardianship and administration. So this is when someone actually lacks decision-making capacity and we need to put something else in place for that, is what we would call a substitute decision maker. So either I can make the decision myself if I have capacity. If I can't make the decision, someone else makes it for me. So it's a substitute decision maker. We don't have a legislative framework that allows for a support person or to make a co-decision. Victoria has some legislation that has started to introduce some of those things. We don't have that here yet. But if we look at the principles that are embedded in our legislation, they do tell us that we should be looking to support people as best as we can. So they talk about things like using the least restrictive option, it being a last resort, those kinds of principles, considering the wishes of the person, and all of those sorts of things tell us that we really need to be doing everything we can to support people to make whatever decisions they're able to make before we ever remove any of their autonomy to make those decisions. So there's some of the limitations. In terms of opportunities, I think there are a huge amount of opportunities. Events like today, guidelines like the guidelines just being released, just that general partnership, the general shift in our cultural shift from moving towards much more of a partnership model where we actually involve, we work in partnership with consumers, patients, with carers, their families, their support systems, where we really do that. But it is about a cultural shift and it is about education, and I think that's one of the most important areas that we can focus on as hospital providers, but it's also about vocal consumers and carers who call us to account, and that's really, really, really key. So keep doing that.
Thanks, Rachel. Okay, Dr. Sook-Lee. We talked about an example. I'm wondering if you can provide the audience with the example that you gave me where you supported a person with a cognitive impairment to make an important health decision. So specifically what, as a medical doctor, and Rachel talked about the risk and balancing that, and how did you work with that person and I think they had a guardian in place as well, a formal guardian. So how did you approach that to get to the person's health decision?
I guess before going into the case, I have to say, I think as a medical professional, and perhaps in the hospital, we're probably a bit risk averse, and coming from the tenets that Rachel has mentioned about doing no harm, I think that sometimes it's really hard for medical doctors to actually accept that, yes, people might make different decisions to what we think is, you know, best practice or best for the person. So I think that's still a really big paradigm shift for us as doctors, and again, with those competing interests, not saying that it's impossible. I'm really lucky that as a geriatrician, I think that we're kind of maybe we're allowed to take a bit more time with our patients, and I think, you know, speaking to this case, I was involved in looking after a person who was having, who'd had previously a stroke and probably some cognitive impairment related to that stroke. They were living at home alone, and they'd had multiple presentations to hospital as a result of falls, the latest of which actually led to a long lie. They were quite deconditioned and they had to go into hospital. This person has actually had a guardian who was actually their friend. And I guess whilst they were in hospital, the concern was about these multiple presentations and whether or not it was actually, you know, was it in the patient's best interest to go into care, and was it at the stage where their care needs were perhaps, you know, transitioning to needing to be in residential care somewhere where there was, you know, 24/7, you know, nursing support. And actually one of the things that transpired was that there was we in geriatric medicine love a multidisciplinary team and love a family meeting. And in this case, what was really important was actually identifying not just, you know, obviously the person's wishes and desires, which were very much, I want to go home, which is pretty common for my patients that I look after, but also recognising that there was a guardian, and also fortunately for this person, actually quite an extensive support network that were friends, as well as a case manager from their care provider. And actually, you know, I guess our job as a medical profession and in the allied health is to, you know, spell out, I guess, what we perceive as the risks. And, you know, in this meeting, it was, you know, I guess laid out in a sense for this patient and their guardian and their support team. And actually what was really important was, I guess, from a medical perspective, certainly the recommendation was for transitioning into care. But listening to the person, the patient that we were looking after, actually, their biggest fear was that going into residential care was going to be detrimental to their mental health. And they were able to have that. I guess what was the important thing for me was that they were able to, I guess, have that forum and articulate that to their guardian and their care provider. And look, I'm not saying that everyone walked away feeling comfortable with that decision, but I think it was a really powerful example of everyone just hearing the voice of the patient and the person that we're talking about, that we're trying to provide this best care to. And I guess supporting, in a sense, I was saying to that part of this was also supporting not just the person, but supporting the decision maker, and actually also sharing that that risk and sharing that tough decision making as well as medical professionals, and not just kind of pushing it back to you know, the patient and their you know, supported decision maker.
Thank you. That was, we might head down to Sam, if that's okay. Yes, thank you. I think that is a good example when you talked about the decision maker. That was a substitute decision maker in that context. So I'm sure the easiest route would have been guardian make a decision, but that perhaps would have been a very, I don't want to say that wasn't what the person wanted, that the decisions that may have been made in their best interest. So by working with them and them communicating that the mental health aspect would be more injurious or more damaging to them, could figure out a way. And it sounded like it was a good outcome for them.
I think in a sense, yes, but I guess it was still risky, the situation, but I think being able to have that dialogue and actually being able to hear what the patient's concerns actually were was actually helpful for the decision maker and also the care provider to actually go, well, look, there's no right answer on this journey, but at least it's trying to support that person in the best way possible.
Yeah, great, thank you. And I think that speaks to the framework that hospitals have around quality and care. And I know that they use the word shared decision making, which I suppose is what you were doing in that context. But the shared decision making that happened lended itself really well to the supporter, being able to support them in the decision making. Thank you. Okay, Sam, are you ready for another one? Sam, when at a certain point, you got quite good at getting ready to go to hospital and taking control of your health in what sometimes is a very worrying. Sometimes it's very worrying for you when you need to go to hospital, like you might be in pain, you might not know what's happening sometimes. And there's some things that you've done with Alex's support and the support of your service provider to be able to have a good hospital experience, or the best chance of a good hospital experience. So can you tell me about some of the things that you've done to be ready or for when you go to hospital to make sure that you're listened to? Yeah. So you talked about when we had, I know this is a very, this is a big room. When we met, you had a lot to say about this actually. You talked about taking Alex or someone that knows you. Why do you do that now? Why do you say, no, I need to have someone with me?
Does a head in.
Does your head in? Yeah. What does that mean? What is that when it does your head in?
Well, one of the things that you helped was that has Sam's communication needs and food needs and other aspects that's updated by the provider and goes with it. But we had our best hospital experience just recently at Gairdner Hospital, and it was because the provider sent a staff member who knew Sam with her, and they went in their own van and not in the ambulance. Sam had a fracture, an L2 fracture to her back, so it was an immense pain. She's toughed it out for 2 or 3 days. Eventually, she said to her provider that she needed to go to hospital. They phoned me, and so then we started the process. It was a 14-hour admission process that carer stayed with Sam through all that process. And so when she got admitted, there was a really clear understanding about Sam does not like MRIs. Failure helped. And so it went forward. Having people around you mattered.
Yeah. So you talked about going in the van rather than taking the ambulance. Why did you make that choice in this case when you're in a lot of pain, you're very worried? Why did you go in the van, Sam?
Couldn't move.
And you wanted to take your wheelchair? And when you go in the ambulance, what happens? Tell everyone what happens when you go in the ambulance. They might not know.
She gets transferred onto a bed, obviously, from a chair, and a chair gets left behind.
Yeah. There's also, so that's really helped. That's really helped having a good process that's communicated. Sam, Alex knows what you want because you've talked a lot about it. Your GP at Derbyl Yerrigan, have they been helpful for this as well? They've been good. What are some of the things that they've done to help with this as well? What makes them good? Why do you like Derbyl Yerrigan?
Dr Jess has a long number of appointments and conversations has decided not to over-medicalise Sam. I mean, Sam has only 2 medications now, whereas previously she had upwards of 8. Plus the main part of that dialogue with the doctor is informing Sam of her own health. There's various things that can assist her. Sam wants to eat really well, and so diet's been important in maintaining your health. And then the other one is mainly the provider is much more switched on now to the care needs that Sam has and Sam expresses. So it's really been important that Sam is respected for her choices and having somewhere, as a good example, junior, what was it, staff, it's been mentioned up here where because Sam's speech is hard to understand, they think that Sam doesn't understand them, so they start speaking loudly and very slowly. It gets up Sam's work real big.
And then they run, don't they, Sam? You get cranky. They get cranky, and you don't want the microphone.
So, look, the last hospital visit was just marvellous, and it was because of the care provider accompanying Sam and being with her. And between myself and them, we would alternate days of being at the hospital with Sam to ensure that good information is passed between the nurses and the doctors and Sam.
Yeah. So I think what I'm really hearing about that is that this is a whole system. So Sam, you're making decisions, you're supported by someone you trust, your disability service provider where you are supported, are on board with that, and with your meals and all the bits that go to keeping you healthy and well. So you can get on with supporting the West Coast Eagles or whatever it is that is happening at that time.
That's also been a journey. It wasn't always like that. So
No, it wasn't,
the
yeah.
last 3 to 5 years there's been great improvements and we've seen that happen. And there's some, yeah.
Yeah, okay. Thank you. Thanks for sharing and being so open about that. Susan,
Yes.
We have only got 5 minutes left. Very quickly, if someone is in hospital and a clinician wants to know whether the person that's there is a genuine decision supporter, what are some of the signs?
Great question. So I'm just going to go back to a couple of principles. Supported decision making is a process. It's not about an outcome. It's about a rigorous kind of process. And in that process, you would see that the decision supporter brings some neutrality to it. They may have to acknowledge that they have some bias. We all bring bias to those sort of contexts. But that may be to the point where they need to say, actually, I'm not the best person to support you with this decision because I feel very strongly about the way it should go. But sometimes if we simply just acknowledge that we have that bias and then we seek to be neutral in supporting the person to work through the information, to explore the options, to weigh up the risks and benefits, then that can help it to be a more rigorous process. I guess one of the things that the research has really shown is that you need to start from an assumption that you see a person as a decision maker, because if you don't start with that assumption, you won't actually notice their expressions of preference and will. You actually have to be starting from that assumption in order to notice that. One of the quotes that we had in a recent project that we've been doing at WA's Individualised Services, and this is with people who don't use words to communicate. So, you know, it's a very creative process of determining what is their preference here, what are they telling us, what do we know about them from way back that informs this decision. And one of the people in this person's network said that it had occurred to them as they developed their decision-making capability as a group, that in fact this person had been making decisions all the time. And it was the decision supporters who had not noticed that. She had been communicating her preferences around all sorts of things, and it actually took a whole lot of focus and intention for the decision supporters to actually begin to notice that and go, aha, we hear you now, and our next process in this is to assist you to act on your decision.
So Susan, again, we're launching the hospital stay guidelines today, and there's those 3 sections around the role of the person and their family, friends, carers, disability service providers and hospital staff. I think from what you just said then is that we can see that a lot of this work needs to happen before someone is in hospital to understand what their preferences and will is, so we can communicate that. Is that fair to say?
Yeah, it's much more likely to be an authentic and effective process if people have time and information to understand and make a decision. And a lot of that, as you say, can happen before they even get into the hospital setting. But it's also true to say that there are plenty of people who come at very short notice to hospital and who don't come with rich social capital in their lives. So that's, I guess, putting a bit more of an onus on the people in the clinical setting to be very attentive. I did notice in the State Disability Framework document there that there's a commitment to, talked about inclusive information. I'm taking that to mean as accessible information. I think that's a real area of development that could happen in the clinical setting when there's routine procedures and tests and things that people are coming in for, to actually invest in visual supports that assist anybody to understand what this decision would look like if it's being implemented. And I'm just recalling as I'm saying that what Piers Gooding was saying is that when we make buildings physically accessible, we provide that kind of notion of a ramp, we all benefit. And the same would be true if we had more accessible information.
Yeah.
That would be of benefit for anybody.
Thanks, Susan. I know we're nearly up for time, but there's a question that we have to answer. So, Rachel, this one's for you. Do you need some water? Someone? Okay. So, this one is more focusing on mental health, because that's a really tricky space that people get confused in. So, what is the most effective way of ensuring the right to supported decision making is upheld in a mental health care setting, even if the person is on an involuntary treatment order? Just an easy one. Yeah. Quick. Yeah.
I'll make it quick. Look, for me, what I always like to think of first is what are our guiding principles. What is it that tells us how we should be operating and working? And if we look at the Mental Health Act and we look at the charter that sits within that, it's really clear about some of these principles. And in particular, there's a number that are especially relevant, and one is the opportunity for consumers to make their own decisions is actually spelt out in that charter, and that operates regardless of whether someone is involuntary or voluntary. There are a couple of other principles around protecting human rights and ensuring that the care that we deliver is unique, and that involves making sure that we are considering the person's needs, preferences, their values, etc. They're very lofty things that guide us, and then we think about the kinds of policies, processes, procedures that we need to have in place. And so having things like the guidelines that are just being released. Within a mental health setting, we work with people to develop management plans, and they should be collaborative management plans. So we should be talking to them about what they see their care and how they want their care to be delivered, or for us to be working together. There's within the Act, there's a function to nominate a personal support person as well. Again, very much utilising that.
But really, you can have all of these kinds of things, all of these sorts of documents, but it's about setting a culture that actually supports this, and to set that culture for people to understand that that exists regardless of whether someone is involuntary or voluntary, and that that applies to those people. So I know we're out of time, but hopefully that touches us a little bit on some of the things.
That's great. Thank you so much, Rachel. We are out of time. Can you please thank our panel for being so open? This can certainly be a difficult conversation to have, and when to apply it and how to apply it. Hopefully there's some thought that has come out of what we discussed now. But otherwise, I'll hand back over to Jocelyn and Steph, and our panellists are free to move back to their seats. Thank you. You too. Yeah, my mind. Mel.
Okay. Who's got the microphone? Well done, Danielle, for facilitating, and for Susan, Sam, Alex, Rachel, and Dr. Lee for contributing to this important conversation. So thank you. I'd now like to invite Lara Moltoni, Executive Director for Safety, Quality, Governance and Consumer Engagement, to provide an update on the North Metropolitan Health Services Disability Access and Inclusion Plan 2022 to 27. Thank you.
Well, good afternoon, everyone, and thank you to all the panellists. That was really, really fabulous. To Steph, Jocelyn, Danielle, and particularly Piers, thank you very much for sharing your personal experience and really making that real for us. We're extremely grateful for your time and for your insight and clear passion and knowledge in this space. So thanks. I can see you on the screen, Piers. So throughout this year, a lot of work has occurred at North Metro to develop a new Disability Access and Inclusion Plan, our DAPE. And I'm very pleased that we can launch the North Metro Health DAPE 2022 to 2027 in time for International Day of People with Disability coming up this Saturday. The new DAPE has been developed in consultation with our consumers. 2 rounds of community consultation were undertaken with people with disability, their family members and carers, staff with disability and community advocates. The feedback we received helped us shape strategies for each of the 7 outcomes of the DAPE. These strategies are soon to be supported by an implementation plan covering all sites and services within North Metropolitan Health Service in early 2023. But to give you a taste of what is in the new DAPE, I wanted to mention some of the initiatives planned under each of the 7 outcomes. So under outcome 1, it asks us to improve access to our services. So we will be making sure all information that may be relevant to our consumers with disabilities, as well as their carers and other visitors, is collated in one place and easily available when needed. Under outcome 2, we're seeking to ensure better physical access to our sites. We will be undertaking audits of our current facilities and buildings to identify where we can make those kinds of improvements. We are very proud to unveil our universal accessible toilets and accredited changing places bathroom in E Block at Sir Charles Gairdner Hospital last year, and that was in response to staff and consumer feedback. We're always looking for more ways to make accessibility more practical for people. As part of our activity for outcome 3, we'll be focusing on incorporating easy read principles in our printed materials, and I know we just mentioned that briefly a moment ago. So that benefits not only people with learning disability, but also people who are not familiar with English or perhaps have lower health literacy. As part of Outcome 4, we will be increasing staff understanding about diversity and the different types of disability and how to best communicate with people with disability. And I think that stems directly from what we were talking about before around the hospital stay guidelines. Some of our sites will be trialling the Disability Health Profile Form, as earlier mentioned, in the launch of the hospital stay guidelines. And we're really looking forward to that and receiving the feedback on that and how we can then build that back into our practice ongoingly. Under Outcome 5, we'll be making sure that we monitor the feedback we receive about disability access and most importantly, report back to consumers and the outcomes. And I'm really interested, Sam, in your story, and I'd really, with your permission, like to perhaps provide some feedback back to Joondalup with your latest episode, so it's really important to us. Outcome 6 calls for more engagement with consumers, and this is a key focus of this DAP, and it is with our health service more broadly with the development of the North Metro Health Service Partnership Model. Again, that was briefly mentioned a moment ago. This model aims to improve consumer experience by building a consistent practice for how North Metro designs, delivers and evaluates health services together with the people who use them. The partnership model will help North Metro achieve its strategic priority of people-centred care and support consumer engagement for upcoming projects such as the relocation of the Women and Newborn Health Service to this QE2 campus. And can I just say, if anyone's has some interest in the partnership model, please don't be shy and come and have a chat to me later. And finally, under Outcome 7, the DAPE also strongly aligns with the North Metro Health Workforce Diversity and Inclusion Strategy 2022-2025, which is about attracting and developing more diverse employees in North Metro to better reflect the community we serve and ensure they feel welcome and included. Our next speaker, Kat Johns, will talk more about a staff disability network being established to help achieve this. I would like to thank all the consumers and North Metro staff who participated in developing our DAPE. It's been an awful lot of work, and I know my team have worked extremely hard over the last 12 months to get that all together. Their input has been vital to this process, and I look forward to sharing news of our collective achievements in the coming years. You can access the DAPE using the QR code or the link, and copies will be made available in the stall outside, and I encourage everybody to please take a copy. So I thank you all very much. I very much hope you've enjoyed today. I hope it's been informative, and I look forward to meeting up with you all in the foyer afterwards. But I think I'm now handing over back to Kate, perhaps, or the...
Yeah, oh, sure.
So Jocelyn, thank you very much, everyone.
Thanks. Thanks, Lara, for the update on the DAPE. I'd like to now introduce Kat Johns to launch the Staff with Disabilities and Allies Network. Kat is one of the consumer representatives for our DHN Executive Advisory Group. Kat also works for the North Metropolitan Health Service, as mentioned, and proposed the idea of creating a support network for health staff with disability. Over to you, Kat.
Hi, I'm Kat Johns. Thank you for turning the lights down. I think this is just one thing to be really aware of is the sensory stuff. So I'm a big advocate for, you know, like that sensory input with colleagues with autism spectrum disorder, which is my disability. So yeah, I'm autistic and LGBT, or specifically more L and G. But a little bit T as well. So yeah, some people, I refer to this as being on the double rainbow. So it's kind of like, you know, the spectrum. I got really confused, like when I started getting involved with some autistic people in the community, and then they started using the rainbow, and I was like, oh, but the rainbow, that's already used. But it seems to be something that people use as a general sort of spectrum thing. So yeah, I like to think of myself as being on double rainbow. So I wanted to work with some colleagues from the Disability Health Network and colleagues with disability to develop a WA Health specific network across WA Health. So just to be clear, this is a health network focused on WA Health employees. So that's, you know, the HSPs, the department. I won't go through all the agencies under WA Health, but if you work under WA Health, we'd love to have you involved. This is for anyone to get involved with who is either a person with a disability who works in WA Health or an ally. And, you know, I'd love to talk to anyone later about this new network that's been launched just now, about what it means to be an ally, if anybody wants to talk about that, about what it means to join the network. There are some flyers outside on the stall, and I will be out there after this to talk to anybody who's interested. The disability, I'd just like to really thank the Disability Health Network leads who have really supported the development of this. And a fair bit of work gone into, you know, kind of figuring out what the network's for and who can be involved and that kind of thing. So we have quite a few staff involved already, like a number of staff involved, and we're growing. So yeah, please do get involved in this. And, you know, I'm very excited about it. I think it's really just hopefully going to be a really good space for staff to get staff across WA Health to get involved with, to collaborate with each other, to develop a kind of safe space, and really just to kind of be really proud of who we are as staff with disability across WA Health. And I think that if we can really create an inclusive environment for WA Health staff, we can really then produce better services for people with disability who are coming to our services, because we will all understand more about each other and each other's needs. So obviously also the sector at the moment is facing some really big challenges with staffing, and I think, you know, being a really inclusive employer, we're going to attract more health staff who, you know, and health staff with disability, I think, really going to contribute to the workplace and ensure that our services are you know, really good. So I just think, you know, making the workplace happier and more inclusive is just really important. And it's very good to see the date being launched today as well. Very excited about that. So anyway, please do come and talk to me outside on the stall if you want any more information about this new network. And thanks to everybody who's been involved in it so far. Hope it can continue to grow. Love to have all your involvement, so please do get involved if you can and want to. Thank you.
Thank you, Kat, for coming to us with this idea and for driving it, and to celebrate the launch today. It's a tribute to you. And all the hospital staff and health staff in the room today, please share this with your teams so that all health staff are aware that there is this new network. Thank you everyone for taking the time. I know it's quite a long event. Thank you for taking the time to learn about the Disability Health Network and North Metro's activities in the disability space, and how you can embed supported decision making in your everyday practice. Please connect with the Disability Health Network if you're not already. You can sign up to the Health Network's bulletin and stay up to date with the Disability Health Network. Our details are up on the screen should you wish to get in touch.
Before you go today, one last time, if you can please get out your phones. We kindly ask if you can complete the event evaluation to help us improve and continue this important celebration. As you can see, there is a QR code on the screen to complete it online, and there is a paper form available. I'll just give you a moment to scan the code, or if you prefer a paper version, please raise your hand and one of the team will run out with a paper version for you. Anyone else? And anyone else up there? Whilst you are completing this, we have one final treat, the story of Paul, who lives a vibrant life with the help of supported decision making. Thank you, WA Individualised Service and the Lives We Lead project for sharing Paul's story. So enjoy.
I'm an easygoing dude. I live in the moment. I live with a housemate. It's a chill place. I like to have things a certain way. My space, my thoughts.
Your Basil's going off out the front. We should do another projector movie day and mental health day or something soon. That's the answer to that book. Yeah.
I get to do what's important to me, like hanging out with my friends. And what's life without a bit of adventure? I love the Freo life. Nature, cafes, nightlife, and the music scene. I have my own business, helping people recruit more efficiently. I like to help others. I choose my team. The ones I can trust. It makes all the difference. Having my own place makes all of this possible.
Thank you. That concludes our online event. Thank you all for attending. For those in the room, please join us for light refreshments and networking in the foyer. Copies of the guidelines, the North Metro DAPE and other resources are available there too. But before you exit, we've got one last request. We did this last year. We're wondering if everyone can move into the centre and we'll have a group photo so we can remember this event.
Thanks, everyone.
Thank you. Thanks, everyone, and enjoy the rest of your day.
See if we can gather some people.